This document is a case report titled, Cushing's Myopathy in Dogs, Prevalence, Clinical Abnormalities, and Response to Treatment. It explores a rare muscular complication associated with Cushing's disease in dogs, also known as hyperadrenocorticism or HAC. The study investigates the occurrence, clinical signs, diagnosis, and treatment outcomes of this condition. The authors note that muscle disorders stemming from metabolic diseases, such as Cushing's, can significantly impact affected animals. They retrospectively assessed canine patients with muscular disease linked to Cushing's, along with historical cases. The goal was to ascertain the prevalence of these complications and determine effective treatment approaches for improved quality of life. The authors found that while rare, these complications severely impair the quality of life of affected dogs. Unfortunately, the study indicates that once diagnosed, there is limited potential for reversing clinical changes, highlighting the importance of prevention and early detection over treatment. The study defines myotonia as a movement disorder characterized by impaired muscle relaxation after contraction, often improving with continued activity. It can lead to muscle hypertrophy and difficulties in joint flexion. Electromyography or EMG, a diagnostic tool, reveals repetitive, high-frequency discharges that create a distinctive dive bomber sound. These discharges, unlike those in neurogenic disorders, are not blocked by neuromuscular agents. In dogs with Cushing's disease, muscle pathology is typically atrophic, causing weakness, but in rare cases, it can cause stiffness and increased muscle tone. This form of myotonia is associated with specific electrophysiologic changes. Pseudomyotonic discharges differ from myotonic ones by starting and stopping abruptly without the waxing and waning pattern. The paper notes that electrophysiologic changes in dogs with Cushing's were first described in the 1970s, with limited research in the past 5 decades. The study aims to address this gap by evaluating a larger group of dogs with hyperadrenocorticism to determine the frequency of clinical myotonia or pseudomyotonia, and to describe the diagnostic process and response to treatment. The authors hypothesized that myotonia and/or pseudomyotonia related to hyperadrenocorticism would be rare. The Materials and Methods section describes a retrospective study involving medical records from 3 veterinary institutions between 2010 and 2021. The researchers searched for dogs diagnosed with adrenal disease and myopathy. Inclusion criteria required EMG results showing myotonic or pseudomyotonic discharges, along with a diagnosis of hyperadrenocorticism either clinically or biochemically. Muscle biopsy results were included if available, but were not essential for inclusion in the study. The collected data included the patient's breed, diagnosis, weight, age at the start of endocrine and myotonia-related symptoms, history, method of Cushing's diagnosis, disease progression, pain indicators, medications, physical and neurological exam findings, blood and urine tests, imaging results, EMG and biopsy findings, treatment and responses. The prevalence of HAC myopathy was determined by dividing the number of identified cases by the number of new HAC diagnoses at each institution from 2010 to 2021. Statistical analysis was used to describe the data. The results section identifies 15 cases that fit the search criteria. However, 5 cases were excluded for lacking clinical or diagnostic evidence of Cushing's disease, or not having myotonic discharges. The diagnosis of pituitary-dependent Cushing's disease was confirmed using a low-dose dexamethasone suppression test or LDDST, or an ACTH stimulation test. Some cases were diagnosed based on clinical signs, chemistry results, and/or abdominal ultrasound, while one case had an unknown cause of hypoadrenocorticism but was included due to steroid administration and myotonia. It is important to note that no cases of adrenal-dependent Cushing's were found in this study. The prevalence of HAC with myotonia or pseudomyotonia was found to be 1.4% at one institution, 0.46% at another, and 0.28% at the third, with an average prevalence of 0.71% across all 3 institutions. The study found that the affected dogs were mostly spayed females or neutered males, with no intact dogs reported. The dogs' weights ranged from 3.62 to 15.3 kilograms. The onset of endocrine disease ranged from 3 to 10 years old, while myotonia onset ranged from 4 to 13 years old. The difference between the onset of myotonia and endocrine diagnosis ranged from 0 to 2 years. The progression of myotonia symptoms was chronic and progressive in 6 cases, chronic and static in 1 case, and acute in 1 case. Some of the dogs were reported to be painful, while some did not have a pain response noted. The dogs had various skin changes such as alopecia, thin skin, hyperpigmentation, comedones, hyperkeratosis, calcinosis cutis, and papules. All dogs also experienced muscle changes including contractures, rigidity, atrophy and/or hypertrophy. Some dogs had hepatomegaly and/or a pendulous abdomen. Table 1 summarizes the physical exam findings. All 8 dogs showed dermatologic changes. 7 out of 8 had muscle contracture or rigidity, half showed muscle atrophy, a quarter had muscle hypertrophy. Hepatomegaly was noted in 3 dogs and a pendulous abdomen in 2. Neurological exams showed that 4 out of 8 dogs had gait abnormalities, including stiffness, bunny hopping, and ataxia. 7 out of 8 dogs showed proprioceptive deficits, some in all 4 limbs, some in the pelvic limbs only, others in the thoracic limbs, and 1 hemilaterally. Decreased reflexes were noted in 7 of 8 dogs, some associated with increased muscle tone. 2 dogs had generalized muscle weakness, and 1 had muscle tremors. No changes in mentation or cranial nerve deficits were noted. The study determined that all 8 cases showed neurolocalization to the motor unit, with 2 cases having concurrent spinal cord involvement. Complete blood counts or CBC were performed in 7 out of 8 cases. Most dogs had abnormalities, including leukocytosis, neutrophilia, lymphopenia, eosinopenia, thrombocytosis, and anemia. Serum biochemistry tests were performed on 7 out of 8 cases. The most common abnormalities included elevated ALP, ALT, AST, CK, hyperalbuminemia, hypercholesterolemia, hypocalcemia, hypercalcemia, hypertriglyceridemia, and hyperglycemia. Urinalysis was performed in 5 out of 8 dogs. Some dogs had proteinuria, and some had minimally concentrated urine. Thoracic radiographs were performed in 5 cases. Some of the dogs had normal results, while others had hepatomegaly, degenerative joint disease, or an enlarged proximal descending aorta. Abdominal radiographs were performed in 1 case, with no significant findings. Abdominal ultrasounds were performed in 5 cases. Some cases showed hepatomegaly with a hyperechoic liver, gallbladder abnormalities, kidney abnormalities, and adrenal changes. Spinal radiographs in 1 case revealed articular facet arthritis, and a spinal MRI in 2 cases showed intervertebral disc disease in 1, and normal results in the other. All electrodiagnostic studies were done by or under the supervision of a veterinary neurologist. EMG was performed in all 8 cases. 4 cases showed pseudomyotonic discharges, 4 cases showed complex repetitive discharges, and only 1 case had myotonic discharges. 1 case report stated that the EMG was consistent with a generalized neuromuscular disease, but specific details were unavailable. Motor nerve conduction velocity or NCV was performed in 3 cases, showing normal results in 1, mildly delayed NCV in another, and demyelination in the 3rd. Muscle biopsies were performed in 5 out of 8 dogs, with 3 reports available. The muscle samples varied, including quadriceps, biceps femoris, triceps, and semimembranosus muscles. The histopathology of the samples showed variability in myofiber size, type 1 fiber predominance, excessive lipid droplets, and lobulated fibers, all consistent with endocrine myopathy. Nerve biopsies were performed in 1 case, but no report was available. Cerebrospinal fluid was sampled in 2 dogs showing elevated total protein. Some dogs had negative urine cultures and other dogs showed mild inflammation in arthrocentesis samples. Liver fine needle aspirates showed moderate vacuolar hepatopathy in 1 dog. Infectious disease testing was done to exclude other diseases. The dogs in the study received a range of medications, including gabapentin, tramadol, carprofen, methocarbamol, diazepam, dantrolene, procainamide, phenytoin, and mexiletine. Some of the dogs received vitamin B12 injections, coenzyme Q10, and carnitine supplements. Physical rehabilitation was prescribed for some dogs, with varying results. Some dogs were also treated for HAC using mitotane or trilostane, and others were weaned off of prednisone. Some dogs did not receive HAC-specific treatments. Necropsy was performed on one dog who had to be euthanized. The results showed diffuse central nervous system or CNS granulomatous inflammation, hepatocellular vacuolation, lymphoplasmacytic enteritis, and pulmonary edema. The discussion section notes that the study identified 8 cases of HAC-associated myopathy, with an average prevalence of 0.71%. Most dogs were diagnosed with pituitary-dependent HAC, one with iatrogenic HAC, and one with hypoadrenocorticism. Iatrogenic HAC was suspected when patients on oral steroids showed signs of Cushing's. The findings are consistent with previous reports, where most cases of myotonia were associated with pituitary-dependent HAC. No cases of myotonia/pseudomyotonia were linked to adrenal-dependent HAC. A case of myotonia developed in a dog treated for hypoadrenocorticism with prednisone and fludrocortisone. Clinical signs included muscle stiffness that progressed over 5 months, and clinical pathology revealed leukocytosis, elevated ALP, ALT, AST, CK, and hyperglycemia. This dog's treatment included reduced prednisone dose, discontinuation of fludrocortisone, and mexiletine, methocarbamol, gabapentin, carnitine, and physical therapy, but was ultimately unsuccessful. Some dogs in this study also had concurrent hypothyroidism, and were treated with thyroxine, raising the question of whether this could contribute to an increased risk of developing myotonia-like symptoms compared to dogs with HAC alone. All dogs in this study had a chronic history of HAC, with an average duration of 12.6 months between HAC onset and myotonia diagnosis. The findings suggest that the development of myotonia is more likely in patients whose Cushing's disease is poorly controlled. Common neurologic signs included proprioceptive deficits, decreased reflexes, and a bunny-hopping gait. The neurological findings in this study indicated neurolocalization to the neuromuscular junction. Common CBC abnormalities included thrombocytosis and a stress leukogram. The most common chemistry abnormalities included elevations in ALP, AST, ALT, cholesterol, CK, and blood glucose. Urinalysis showed proteinuria. These findings are all consistent with poorly controlled HAC. The most common EMG findings included pseudomyotonic and complex repetitive discharges. Muscle biopsies showed selective type 2 fiber muscle atrophy, type 1 fiber predominance, and replacement of myofibers by adipose tissue, consistent with non-inflammatory endocrine myopathy. The treatments for this condition were variable. Analgesics were the most common. Steroid weaning or HAC treatment was recorded in some cases, as were muscle relaxants, sodium channel blockers, and supplements. Most dogs showed no significant improvement, with one dog remaining static, and one lost to follow-up. The vast majority of the cases in the literature did not improve or had progressive disease. The study concludes that the treatment for this condition is not well understood. Despite this, the study recommends that underlying HAC should be treated even without improvement in the myotonia symptoms. Given the lack of improvement to treatment, the study underscores the need for better treatment strategies. Early diagnosis and treatment of HAC or the removal of prolonged steroids may be the most critical factors for prevention given the poor response to treatment. The conclusion section recognizes the study's limitations, including the small sample size, incomplete medical records, and presumptive HAC diagnosis in some patients. Not all cases had complete EMG tracings, and muscle biopsies were performed in just over half the dogs. Due to inconsistent treatment strategies, the study was unable to evaluate whether HAC with myotonia/pseudomyotonia is truly refractory to treatment. The authors suggest future studies focus on consistent evaluation of a particular therapeutic strategy. From Vet NeuroJar, keep those minds inspired, hearts light, and tails wagging.